Imagine spending 8 weeks doing bicep curls, right? Like tracking your reps, looking in the mirror every single morning.
Yeah, feeling definitively stronger.
Exactly. But then you step on this specialized scale and find out you haven't built a single millimeter of new muscle.
Oh, wow. Yeah, that's frustrating.
Right. The strength you feel is entirely a neurological illusion. Basically, your brain just tricked you into feeling cured.
I mean, that is the exact physiological trap that millions of people fall into when trying to rehabilitate their pelvic floor.
It really is.
We treat this part of the human anatomy like, well, a mysterious, muddy swamp. If you break your arm, an x-ray gives you a jagged white line, right? A definitive binary diagnosis and a very clear timeline.
Yeah, you know exactly how many weeks the cast stays on.
Exactly. But the structures of the pelvic floor are invisible to the naked eye. They are deeply intertwined with our subconscious nervous system and heavily influenced by how we sit, breathe, and, move every single day.
Which makes measuring progress incredibly frustrating for anyone actually going through it. So, welcome to this custom-tailored deep dive. We have one highly specific mission for you today.
Just one.
Just one. We are ripping through a massive stack of clinical guidelines, physical therapy clinic notes, and medical research to answer the burning question. How long should you actually commit to structured pelvic floor rehabilitation before evaluating if the treatment is genuinely working?
And we are pulling from everywhere for this.
Oh, yeah. We've got the UK's nicest guidelines, physical therapy protocols from Ventura Orthopedics and Exchange Physical Therapy Group, clinical trials involving CrossFit athletes, and even morphological examinations of rat models.
Right, and the overarching theme in all these sources is a profound public misunderstanding of muscle physiology. I mean, you hear "do your Kegels" from doctors, magazines, fitness influencers.
It's everywhere.
It is, but nobody provides the biological blueprint for how long tissue actually takes to remodel.
Okay, let's unpack this. If I am the patient and I want to know when to throw in the towel or, when to double down, I need to know the baseline. What does a standard successful recovery timeline look like when you aggregate all these PT protocols?
So the clinical data consistently breaks recovery into a 3-phase timeline. Phase 1 is the initial 2 to 4 weeks.
Okay, so month 1, basically.
Right. And during this window, you are not structurally fixing anything. What patients report is just an increase in muscle awareness.
Like they can finally feel it.
Exactly. They describe a slight reduction in symptoms. Maybe the heavy pelvic pressure at the end of the day is a little less intense, or they have, a fraction of a second more warning before a leak.
So it's a flicker of life, basically. The area is waking up from dormancy, but the structural integrity is identical to day 1.
Completely identical. Which brings us to phase 2, and this is where the danger really lies. This hits around the 6 to 8 week mark.
The 2-month danger zone.
Yeah. For patients with mild to moderate dysfunction, symptoms often largely subside during this phase.
Wow, really? So early?
Yeah, the leaking might stop entirely during normal daily activities. The pressure feeling dissipates. So the patient feels fixed.
And let me guess, they stop doing their exercises.
They stop completely.
Because, why wouldn't they? If you take antibiotics for a sinus infection and the pain stops, you assume the bacteria is dead.
Right, but I'm looking at these dropout rates in the studies, and if they quit at week 8, they haven't actually changed the hardware yet.
Right, they haven't added any true muscle mass.
Exactly. Which forces us into phase 3. And that is the 12 to 16 week mark. This is the gold standard duration across almost every major clinical trial.
Okay, 12 to 16 weeks.
Yes. The NICE-Bannett guidelines, that's the National Institute for Health and Care Excellence in the UK, they explicitly mandate a supervised program of at least 3 months for stress urinary incontinence.
3 months minimum.
Minimum. And a minimum of 4 months before you even evaluate surgical options for pelvic organ prolapse.
I look at a 4-month mandate, and I immediately think about just how impatient we are with our bodies. If you want a deadlift PR, or you want to train for a half marathon, you fully accept that it takes 16 weeks of grueling, progressive overload.
Of course you do.
But because the pelvic floor is hidden, we treat it like a light switch. Flip it on with a few days of Kegels, expect it to shine brightly. We completely forget these are just skeletal muscles.
Yeah, and to understand why that 16-week mandate exists, we really have to look under the microscope at the cellular reality of this muscle group.
Let's do it.
So the pelvic floor is roughly 70% slow-twitch muscle fibers, your type 1 fibers.
Okay.
These possess massive capillary density and are built purely for endurance. I mean, their job is to stay contracted at a low, submaximal level for 16 hours a day, fighting gravity, holding your bladder and uterus or prostate in place.
So they're the marathon runners holding the structural foundation together.
Beautifully put. Yes, marathon runners. Now, the remaining 30% are fast twitch type 2 fibers. These are your sprinters.
The quick reactors.
Right. They sit quietly until there is a sudden spike in intra-abdominal pressure. So, a cough, a sneeze, a box jump.
And then they fire violently.
Instantly, they clamp down the urethra and prevent leakage.
Okay, here's where it gets really interesting. When you start training this bizarre 70-30 split of marathon runners and sprinters, the physical therapy sources explain that the progress you feel at week 8, that phase 2 illusion we talked about, is almost entirely a nervous system upgrade.
It is, yeah. It's neuromuscular efficiency.
Right.
When you first start training a weakened muscle, your brain is terrible at talking to it. The neural pathways are rusty. By week 8 of consistent training, your central nervous system hasn't built thicker muscle fibers.
It hasn't built the hardware.
Exactly.
Fine.
Instead, it has myelinated the neural pathways. It has figured out how to recruit the existing thin muscle fibers more efficiently and basically fire them in perfect synchronicity.
So you upgraded the software to run perfectly on terrible hardware.
And as we know, terrible hardware eventually crashes. True muscle hypertrophy, the actual biological process where muscle fibers suffer micro tears, synthesize new protein, and physically sicken their cross-sectional area, that requires 15 to 20 weeks of sustained mechanical tension.
I want to dig into how the software communicates with that hardware, because the sources detail this 240 millisecond reflex that completely reframes how I think about continence.
Oh, yeah. What's fascinating here is the concept of anticipatory postural adjustments.
Okay, big words.
Right, but it's simple. In a healthy continent individual, the pelvic floor operates on a subconscious feed-forward loop. Research shows that 200 to 240 milliseconds before a rise in bladder pressure, so before the physical act of the sneeze even leaves your throat, your autonomic nervous system has already sent a signal down the spinal cord.
Wow.
And the pelvic floor has already locked down the hatches.
It's literally predicting the future. It knows the sneeze is coming before the conscious brain does.
Exactly. Pelvic floor rehab is largely about restoring that quarter-second predictive reflex, because brute strength without timing is useless.
Right, if you have the strongest pelvic floor in the world, but it fires 100 milliseconds after the sneeze, you still leak.
You still leak.
That timing aspect brings up a massive paradox in the physical therapy notes. The assumption is always that if you leak or if you have prolapse, your pelvic floor is just weak and floppy.
Right, the floppy ball assumption.
But there is this elevator analogy in the literature that destroys that assumption. It turns out a dysfunctional pelvic floor is often incredibly tight and overworked.
Yeah, the length-tension relationship in muscle physiology dictates that a muscle fiber can only generate maximum force when it starts from a resting, elongated state.
Okay, so like a slingshot.
Exactly like a slingshot. Think about it. If your shoulders are permanently shrugged up to your ears from stress, those upper trapezius muscles are tight, but they are incredibly weak because they have absolutely no range of motion left.
So apply the elevator analogy to that. Imagine your pelvic floor is an elevator. Doing a Kegel, contracting the muscle upward and inward, is taking the elevator up to the 3rd floor.
Right.
But a functional elevator has to return to the lobby at rest. And for bodily functions like going to the bathroom, it actually needs to drop down into the basement to fully relax and bulge.
Yes. And many patients walk into physical therapy clinics with their pelvic floor elevator permanently stuck on the 2nd floor due to chronic stress, or poor breathing mechanics, or trauma.
So when the physical therapist tells them to squeeze, they only have 1 floor left to go. They hit the 3rd floor immediately.
Exactly. It presents as a weak contraction, but the muscle isn't weak. It's suffocating under its own chronic tension.
They literally have to train the software to let the elevator drop back down to the lobby before they can even attempt to build true strength.
Which brings us to the clinical measurement of all this. Because if the first 8 weeks are just software upgrades and a tight muscle mimics a weak muscle, clinicians need aggressive, objective tools to measure if the 16-week protocol is actually altering the tissue.
Yeah, the sources outline the perfect scheme, like the word perfect, P-E-R-F-E-C-T. I read through this, and I got to say, it sounds like a highly invasive fitness test.
It really is. It is the clinical gold standard for vaginal or anal digital palpation. The physiotherapist is manually testing specific variables. P stands for power.
Okay.
Testing the sheer force of the contraction. This is often graded on the Oxford scale from 0, which is no flicker at all, to 5, which is a strong contraction that pulls the examiner's finger up and in against strong resistance.
And they use dynamometers for that too, right? Like actually measuring the intravaginal pressure in centimeters of water.
They do, yeah. It gets very precise. Then we move to E for endurance.
Okay, the marathon runners.
Exactly. Can you hold that maximal squeeze for 10 seconds, testing those type 1 slow twitch fibers? Then R is repetitions. How many 10-second holds can you execute before the muscle simply gives out?
Ouch. Okay.
Then F stands for fast contractions, isolating the type 2 sprinters. Can you do 10 rapid 1-second flicks in a row? And finally, ECT ensures every contraction is timed.
Wow. But I mean, power and endurance on an examination table don't necessarily mean you stay dry in real life, right?
That is exactly where the pad test enters the clinical trials. Researchers weigh highly absorbent pads on a gram scale, have the patient wear them for a standardized 1-hour protocol.
And what does that involve?
Well, it involves drinking specific amounts of water, climbing stairs, coughing, and jumping, and then they weigh the pad again. In longer studies, it's a 24-hour test.
It is the undeniable objective math of urine loss.
It really is.
But if you're listening to this right now, maybe making dinner or driving home, you obviously don't have a dynamometer hooked up in your living room. You aren't going to weigh your own sweatpants on a kitchen scale to do a DIY pad test.
No, definitely not.
So how do you, the listener, know if the hardware upgrade is actually happening over those 3 to 4 months?
Well, you lean on the exact same subjective data that major researchers use. A 16-week clinical trial focusing on CrossFit athletes and functional fitness exercisers heavily utilized daily voiding diaries and visual analog scales.
Avoiding diary. So it just tracks fluid intake, trips to the bathroom, and leakage episodes.
Exactly. So if my diary shows I went from leaking on my 135-pound deadlifts to staying completely dry, or I stopped waking up 3 times a night to pee, I don't need a dynamometer. The physiological adaptation has demonstrably occurred.
Subjective improvement in dually quality of life is empirical evidence of clinical success.
It absolutely is.
So what does this all mean for the daily routine? If I am committing to this 16-week hardware upgrade, I need to know the exact biomechanical triggers that force the muscle to grow.
Right.
Because looking at the American College of Sports Medicine guidelines applied in these sources, doing a few haphazard squeezes at a red light while gripping the steering wheel is entirely useless.
Completely useless. The scientific sweet spot across the literature demands a frequency of 3 to 7 days a week. The volume requires 3 sets of 8 to 12 maximum contractions, and you hold each contraction for 8 to 10 seconds.
But the critical part, the part everyone skips, is the resting phase. The protocol mandates an equal rest period of 5 to 10 seconds between every single repetition.
Yes. Skipping that rest period sabotages the entire physiological process. When you clamp a muscle down for 10 seconds, you are burning through localized ATP and trapping lactic acid inside the muscle tissue.
Right.
And because the muscle is tightly contracted, the blood vessels are squeezed shut. Oxygenated blood literally cannot get in.
So the 10-second rest is a flush valve.
It allows the muscle to return to the lobby, going back to our elevator, the blood vessels to dilate, the lactic acid to wash out, and fresh oxygen to fuel the next rep.
So if you just rapid-fire 30 kegels without resting, you are essentially suffocating the tissue.
Pretty much.
I look at these stats comparing supervised versus unsupervised training, and honestly, the gap is terrifying. Programs supervised by a physiotherapist yield cure rates up to 80%.
Yep. And the unsupervised control groups, the patients handed a pamphlet and told to do it at home, they dropped to a cure rate as low as 9.5% in some studies.
Just under 10%.
Yeah.
Is the unsupervised group just inherently lazy? Or is the physical therapist doing something biomechanically that a patient literally cannot do alone?
It comes down to proprioception and something called the Valsalva maneuver. Without digital palpation or biofeedback, which uses surface electromyography sensors to display your muscle electrical activity on a screen, humans are just terrible at isolating the pelvic floor.
You just can't feel it properly.
We can't. Unsupervised patients frequently bear down, they hold their breath, brace their abdominals, and push downwards, exactly like you would during a bowel movement.
Oh, wow. So they are actively doing the inverse of a Kegel.
Exactly. Driving intense pressure down onto a weakened system, which obviously makes the dysfunction worse. The biofeedback screen or the therapist's physical cue ensures the contraction goes up and in.
And then adherence is the second half of that equation, right?
It is. There is a fascinating mHealth study looking at pregnant women using an app to track their pelvic floor training over 56 days.
Okay, so about 2 months.
Right. The researchers found that women who adhered to the protocol for a minimum of 28 out of those 56 days, so just 50% compliance, demonstrated a significantly lower risk of postpartum stress urinary incontinence.
Just 50%.
Yeah.
So showing up and doing the work half the time, provided the mechanics were correct, was enough progressive overload to structurally protect the pelvic floor from the trauma of childbirth.
Yeah, it really highlights that something is better than nothing as long as it's the right something.
But that raises the anxiety-inducing question for the patient, you know? A 16-week intensive protocol to build the hardware is a definable goal. What happens at week 17?
Right.
Does the listener have to perform 3 sets of 10-second holds every single day until the end of time?
Luckily, no. The clinical framework transitions away from intensive rehab into a 3-stage life cycle: rebuilding, transition, and maintenance.
Okay, so 16 weeks is the rebuilding phase.
Yes, you are actively remodeling tissue architecture. Once the hardware is built and the symptoms fade, you enter the transition phase. The frequency drops to 1 to 3 times a week.
Okay, much more manageable.
Very manageable. You are no longer trying to force the muscle to grow. You are simply defending the gains.
And defending the gains is critical because the use it or lose it principle of muscle atrophy is absolutely brutal.
Oh, it really is. The sources include a morphological examination of rat models that makes this incredibly, well, graphic but clear.
Tell me about it.
Researchers simulated the trauma of a vaginal delivery on the pelvic floor of rats. When they examined the muscle tissue under a microscope weeks later, the unassisted rats showed severe degradation in the muscle architecture.
So the actual cross-sectional area of the muscle fibers shrank, and the tissue was infiltrated by adipose and fibrotic tissue. It basically turned into stiff, fatty scar tissue instead of functional muscle.
Yeah. And human data mirrors that cellular degradation. Studies show that without assisted active muscle training, natural recovery of the pelvic floor stalls out entirely by 12 months postpartum.
It just gives up.
The body just stops trying to heal it. This is amplified in individuals with higher BMIs or those who suffered complex deliveries with a prolonged second stage of labor.
Wow, so if you don't provide the mechanical tension to tell the body to keep the muscle strong, the body just cannibalizes it for efficiency.
Which is why the final stage is the maintenance phase. The targeted, isolated exercises become rare. Instead, the strength is maintained dynamically through daily life. That 240 millisecond reflex is back online.
So you automatically engage your deep core when picking up a heavy Amazon box.
Exactly. It stops being a grueling medical intervention and just becomes standard bodily hygiene.
Right, you don't view brushing your teeth for 2 minutes every morning as a medical rehab program for your enamel. It's just maintenance. Learning to integrate the pelvic floor into a heavy squat or a sneeze is the exact same concept.
So, to synthesize the timeline for anyone navigating this, you must commit to 8 to 12 weeks to secure the software upgrade. You will feel better, but you are not done.
You are definitely not done.
True muscle hypertrophy, the actual physical thickening of the type 1 and type 2 fibers, demands 16 weeks of progressive, properly rested, and ideally supervised loading.
Well, if we connect this to the bigger picture, looking at the trajectory of surface electromyography and biofeedback, the hardware is shrinking at an exponential rate. We treat the pelvic floor like it's invisible, but the technology is pulling it into the light.
It really is. I mean, we meticulously track our REM sleep, our VO2 max, our daily step count, and our heart rate variability right on our wrists. The sensors required to measure intravaginal or perineal muscle activation are becoming cheaper, smaller, and wireless.
So how long will it be until wearable, biometric technology or smart clothing embeds these sensors seamlessly into our workout gear? Will we have an Apple Watch ring specifically for the pelvic floor, tracking the daily workload of those unseen muscles, just like we track calories burned?
It's totally possible. The barrier is no longer technological. The algorithms can easily interpret the electrical signals. The barrier is cultural.
Yeah.
We have to collectively decide to treat the pelvic floor with the exact same biomechanical respect we give our hamstrings and our biceps.
Stop treating it like a muddy swamp. Build the X-ray machine.
Yeah.
Put in the 16 weeks of hardware construction. Let the elevator return to the lobby between every single rep and flush the lactic acid. Thank you for joining us on this deep dive. Take this timeline into your next physical therapy appointment and demand the data. We'll catch you on the next one.